Welcome to the Boston Structural Heart course. Today we'll be going over the high frame rate examination of the mitral valve. We've all been in situations when a very specific diagnosis regarding a pathology in the mitral valve is required, specifically about a structural abnormality, and the patient is in atrial fibrillation or has an irregular rhythm and RR gated acquisition is not possible, and we cannot have a high frame rate and high line density en face or a full volume examination of the mitral valve. So we'll go over the specific methods, the tips and tricks of optimizing these imagings and getting significantly higher frame rates and significantly higher line density to make this diagnosis and to bail you out of this challenging situation. So let's go over this tutorial. So we have a very unique situation. We have a 95-year-old patient who has intractable heart failure symptoms, which are believed to be because of his mitral regurgitation. He has multiple medical problems. I will just stick to the point and not go into the detail, but by our surgical colleagues, he was judged to be a prohibitive risk for surgery and was scheduled for an edge-to-edge mitral valve repair. So what you're seeing in these two-dimensional clips is the mid-esophageal four-chamber view, mid-esophageal transformational view, as well as the mid-esophageal long axis view is a posterior leaflet flail and an anteriorly directed jet. Well, the diagnosis is very simple. It's a posterior leaflet flail, but the question was where to deploy the first clip, because this patient had only one shot at getting a MitraClip, and we wanted to deploy the clip which would result in a maximal reduction in mitral regurgitation severity and minimal increment in the transmitral gradient. So that was the major diagnosis. Whether we go at A2P2 or at which side of A2P2, either A1P1 or A2P or on the A3P3 side of A2P2. So let's take a look. So this is an en face view of the mitral valve in this specific patient, and as you can notice that this is a single beat 3D wide angle, and it has a frame rate of only about 10 hertz, which is kind of dismally low to make a high-end diagnosis like this one, that is specifically to decide which side of A2P2 or the clip to be deployed at A2P2. So therefore we have to do something to improve the frame rate while maintaining the line density. Well, the trick that we need to use in this specific situation is a narrow sector high frame rate examination of the mitral valve in a piecemeal fashion. More specifically, we have published this technique in the past, and that was also to bail ourselves out in situations when R-wave gated acquisition is either impossible or impractical, but we still need a very high frame rate and high line density. And the trick is to use the narrow sector live frustums in a piecemeal fashion, either from the anterolateral or the posteromedial commissure of the mitral valve, and gradually advance the frustum from one commissure of the mitral valve to the other commissure. Now there are three different ways of doing it. Number one is simply moving the probe from the upper esophagus from the anterolateral commissure to the posteromedial commissure. That is an extension of the monoplane examination of the mitral valve. Number two is simply changing the elevation width of the frustum that is coming out of the TE probe, either front elevation, central elevation, or back elevation. And lastly is just changing the elevational position in real time by scrolling the scroll ball on the control of the machine. So in this specific patient, what we used was simply changing the elevation position from the center to the back and to the front, and achieving a very high frame rate, as you will see in the subsequent example. Let's take a look. So as you can see, this is a live wide-angle mitral valve en face view. This is obviously a single beat, and the depth of about 9.7 centimeters and a frame rate of 10 hertz. The question over here was, while we know that the posterior leaflet is the one which has more structural abnormality, but where do we more precisely need to position our edge-to-edge device? The question was whether it should be on the medial side of A1P1 or on the lateral side of A1P1, and this frame rate is too little to make this recommendation with any level of certainty. So we're changing the elevation and using a narrow sector live examination. First of all, we look at the front elevation and the anterolateral commissure with the A1P1 scallops, and compared to our live on-FOSS wide-angle view, as you can see that we are beginning to appreciate a little bit more of the tone chords and the prolapsing posterior leaflet. And now also we have a frame rate of 27 hertz, which is almost 3 times as much. Then we go on to central elevation, again with a frame rate of 27 hertz, again beginning to see a little bit more of the posterior leaflet of the mitral valve. But however, the most difference that we found is, and when you're using the back elevation, the posterior medial commissure, that you can not only see this prolapsing segment of the posterior leaflet, but also seems like some torn chords of the anterior leaflet as well. So therefore, simply by using a live narrow sector and at the same time changing the elevation from the anterolateral to the central to the posterior medial commissure, we were able to increase our frame rate by 3 times as much. And put them all together, you can see that this is anterolateral commissure, central elevation, back elevation with posterior medial commissure, and compare that more to this single beat, single beat wide angle at a frame rate of 10 hertz. By simply changing the elevation and reducing the narrow sector, we have increased the frame rate by almost 3 times as much. Example of another patient who is 85 years old with multiple medical problems, and I'll keep it to the point that it's considered prohibitive risk for surgery, had severe MR with exacerbation of heart failure symptoms and was in the CCU on multiple inotropes. Again, a prohibitive risk for surgery, so we had to kind of do this MitraClip in an emergency and in a short period of time because the patient was very unstable. So time for only one clip at one location. We've got to choose the best one for that. So as you can see from the midesophageal 4-chamber view, there's a flail anterior leaflet. The transformational view confirms that this being the P3, this is the A2 and P1, the A2 leaflet being flail, and the midesophageal long axis view with color flow Doppler confirms that the patient has a flail anterior leaflet with severe intensity mitral regurgitation jet that is posteriorly directed. Now, to remind you that this patient, while appears to be in normal regular rhythm, but had slow atrial fibrillation, and it wasn't possible to do an RF gated acquisition. Again, we needed a very specific diagnosis on where to put or deploy the edge to a device, whether it be smack in the middle at A2, P2, or was one side of the valve prolapsing or flailing more than the other. Certainly, we wanted to have as short time possible in the operating room as we possibly could to achieve the maximal reduction in mitral regurgitation and the most minimal elevation of the transmitral gradient. Again, first we acquired a wide-angle live single beat view with about a frame rate of only about 10 hertz. We can certainly see that most of the anterior leaflet is prolapsing. We can appreciate a flail segment of the A3, P3 side of A1, A2, P2, and some prolapse of on the A1, P1 side of A2 as well. So while it did give us a broad outlook of what the problem with the valve was, which was the anterior leaflet, which we knew with the two-dimensional examination, but we certainly wanted to be very certain of if we want to go right in the middle or we want to bias the edge-to-edge device on one side or the other. So this time again, we went to elevational width changes. Again, the front elevation, central elevation, and the back elevation. And as you can see this time, we've gotten a frame rate of about 38 hertz, but narrowing the sector size. And you can see that now a prolapsing or a flailing segment of A1, P1 is more obvious. This wasn't as well visualized on the A2, on the wide angle single beat. And when we look at the central elevation, while we appreciated the A1, P1 side of it, but now we are beginning to appreciate the A3, P3 side we appreciated, but now we are more appreciating the A1, P1 aspect of the flail of the anterior leaflet as well, And as you can see on this one, there's a certain element of P2 flailing as well. So it was a bit more complicated than we should have known. So it was not just the A2, P2, but either side of it was almost as well involved. And our initial impression of the A3, P3 side being predominantly more involved was not correct, and the A1, P1 side was involved as well. So now if you put it all together, you can see this is the front elevation, central elevation, and this is the back elevation. And now if you put them together, this is kind of a mental reconstruction to put it together, to bring all of three together to make a three-dimensional model of the mitral valve at a frame rate of about 38 hertz of each of them, as opposed to the 10 megahertz one that we achieved with the wide-angle live mode. And we have even eliminated this little artifact on the anterior leaflet just because of an improved line density. So while over here you cannot appreciate as well this flail segment, but clearly you can see in the central elevation that there's more flail involved in the A2P2 as well as on the A1P1 side, and therefore we deployed the clip on this side of the valve. So that brings into brings into value the knowledge of sector size, line density, and frame rate, and knowing which specific aspect of three-dimensional examination is more important at any given moment in time, and to design the exam specific to that clinical situation. I hope you enjoyed this sneak peek of the masterclass in three-dimensional imaging. This is one of the short segments and demonstrates the practical value of the information that we are conveying in this masterclass. As I promised, every bit of information is not redundant, useful, and practical, something that you'll be able to use the day after you finish this masterclass. I hope you enjoyed it. Stay tuned, and hope to see you soon as one of the attendees of the Boston Structural Heart course in August. Good luck.